by the Campbell County Drug-Free Alliance. The Drug-Free Alliance was formerly known as the Southern Campbell County Coalition. It was founded, started maybe about 10 years ago when there were Residents Against Drugs. That was an Alexandria-based group that started to be proactive about substance abuse prevention or substance abuse awareness even. And then the Campbell County school system became involved with Greater Cincinnati Drug-Free Alliance, and we partnered up with Regional Prevention and Health Department and several other agencies, and then that kind of formed the Southern Campbell County Alliance. And we were also very active with Campbell County, or I'm sorry, the Alexandria Police Department. They were very instrumental in all of this as well. So from there, that was about in 2007. From there, we decided we were growing in capacity and in strength, and we went countywide. And last fall, a year and a half ago, we changed our name from Southern Campbell County Drug-Free Alliance to the Campbell County Drug-Free, or Southern Campbell County Coalition to the Drug-Free Alliance, Campbell County Drug-Free Alliance. So we have some members here with us tonight. We have Michelle Eversole, who's with the Health Department, this way, and Sarah White, who's with North Keys Regional Prevention, Pam Huff, who is a parent representative and also an employee of Campbell County Schools and Youth Service Center, Sherry Chan, who is the current chair of the coalition, and she's the coordinator for Dayton's Youth Service Center. I'm Linda Bates. I'm coordinator for Campbell County Youth Service Center, which serves the middle school and high school. Pam and I work together, and those are some of the members here from the coalition. We have some funding from both Physical Court and then Northern Kentucky ASAC group, which has helped funding some of the things that we're currently doing. And one of the things that we have in that grant is to have some town hall meetings and to raise awareness on opiate abuse and the rising trends in heroin use that we're seeing pop up throughout Northern Kentucky. So, without further ado, I'd like to go ahead and introduce you to our panel. On your chairs, you have little index cards. Those are for you to write questions on as the discussion goes on. So, if you would like to write any questions that come to mind, and I'll introduce you to our panel, and then you'll be able to share questions with them. We are on schedule for this from 6:30 to 8. However, we have some more panel members than when we originally set that time, and we are willing to stay here till 8:30 or whatever. So as long as you have any questions, if you need to leave at 8, that's the way we advertise it, then please feel free to go. But if you'd like to stay for more question and answer time, then we'd love to have you here with us. Did everybody get a purple agenda? If you did not, I can have some of our members pass out the agenda. And we also have Campbell County Drug-Free Alliance brochure. If you did not get one of those, we would like for you to get one of those. So if you'd like to raise your hand, we'd be happy to get one of those in your hand. We are currently also, I should let you guys know that we are currently applying for a federal grant. And if we are granted that federal grant, which we will find out in the fall, in August time, then we will be, we've partnered up, as I said, the City of Alexandria Police Department has been an active partner with the coalition since its inception, since way back to the first RAD days. We have actually, our plan is to have an office here within the city building for our full-time employee that will be funded through that DSC grant. So we're very appreciative to the City of Alexandria for partnering up with us in our efforts to enhance the work that we're going to be able to do in the next several years. So, without further ado, I'll go ahead and introduce you to the panel that we have here. Our first speaker will be Charlotte Weddington, and she is a parent and recovery advocate, and she works at Transition, or she's affiliated with Transitions. And then Dr. Kalfas, who is not here at the present, but we are anticipating his arrival any time. He will be talking to us about addictions, and he is a physician practicing in Hamilton County. is that correct? Fort Wright, and Fort Wright, I'm sorry. Okay. Then we have, next we would have Lieutenant Richard Whitford. He's with the Fort Thomas Police Department, and we're very glad to have you join us with this one. You were not at our last townhouse, so we're glad to have you with us today. And then we would have Ashley Cruzcamp from St. Elizabeth. She's a nurse manager. And then Chuck Washburn, also with St. Elizabeth, with he's assistant director for behavioral health. Again, you guys are new to our family tonight, so we're very glad to have you here with us representing the medical field. So thank you very much. So without taking up any other time, I'll go ahead and let Charlotte share her story and what she would like to share with everyone tonight. So thank you very much.
Well, I told Sarah I'm a former teacher, so I have to stand up. So I'm going to come around here and so I'll try to stand so I don't have my back to anybody. But this is the young man that's responsible for me being here tonight. That's Casey. Casey is our son. It is because of Casey that I am now recovery advocate for transitions, and I do work for transitions 3 days of a week, usually. Due to some family circumstances, I haven't been able to be there lately, but I do hope to get back. I never planned to be a recovery advocate. That was not in my life plan, but I didn't plan for addiction to come to our house either. I would like to say that Casey was a good person who made a bad decision to use drugs the first time. He never intended to become a drug addict, but because of the disease of addiction, once he started using, he soon crossed that line from use to abuse and then to addiction. I didn't think that Casey would be a person that would become addicted to drugs, because I think all of us have had that stereotypical idea of what a drug addict looks like. And it certainly wasn't my son. I thought because Casey was loved very much, came from a two-parent family, did not see the misuse of drugs in our home, because he was smart, because he knew about the danger of drugs, because I didn't think he would ever become addicted. But he did. When he became addicted, we didn't really know it, or when he was using drugs, we didn't really know it for sure, but I just had this gut feeling that something wasn't right with Casey. And of course, I didn't want to believe it. I said we were in denial long before Casey got there. And I posed the question to my husband at one point, and I said, "You don't think that Casey is using drugs, do you?" And of course, when I posed the question to him like that, what was the answer that I expected him to give me? Nothing. And he didn't disappoint me. That's exactly what he said. And so we didn't really have the proof that Casey was using. But like I said, I had that gut feeling, as I think moms especially have, and I think dads do to some extent as well. I knew that there was something wrong. I just couldn't put my finger on it. I just didn't know what it was. And I was of the opinion that I should not accuse Casey of doing something without the proof. And so I was constantly looking for proof. I was looking for some evidence that he was using. And I couldn't find it because he was very guarded about his drug use. One thing I'm going to say to you tonight, and I hope if you don't get anything else out of what I say, you will remember this, that if you are dealing with a loved one that you suspect has a problem, don't wait, do something about it now. The sooner that you act, the better the chances are for that person to recover, because addiction, just like any other chronic, progressive, potentially fatal disease, the sooner it's recognized, the sooner you get treatment, and the longer you get treatment, the better the chances are for recovery. We didn't really know that, like I said, that Casey was using until he had left our home and had gone to the University of Cincinnati. He was able to do that because my husband was working at UC and he was able to go tuition free, which was a great opportunity for him and for us, for him to go there. Like I said, up until that point I had suspected. It was only after he had moved out of our home that I really knew for sure that he was using. Because he was at our home one night and he left, and I noticed he left without his backpack. Casey always had his backpack with him. It was like another appendage on his body. And so when he left that evening, I made a beeline for his room, and I went in his closet, and there was a backpack, and in the backpack there was a container of marijuana buds, yay tall. And I brought it out, I showed it to my husband, and he said, yep, that's what it is. Just like that, Jim took it to the basement, threw it in the fireplace, and it was up in smoke. I said, just like Cheech and Chong, it was gone. And so Casey came home that evening, and of course he went in his room looking for his stash. It was not there. He was very distraught. He said, you don't know what you've done. And I didn't really know what I had done at that point, but I would later realize that he owed someone some money for that, and I don't know how he was able to pay the dealer, but and often and really realistically and honestly, I really don't want to know how he came up with that money, but I'm sure he was able to get it to him somehow. So, you know, it was obvious then that Casey was using. There was no doubt about it. He was smoking pot and probably dealing in pot. We made a huge mistake that evening, one that I would live to regret, and that was that we did not call the police. You know, I wish now that I had just put that pot back in the closet in his backpack and waited till he got home and called the police to come and arrest him. I was afraid, and I can tell you this too, that often I think we let fear rule us, and we live in fear, and we make our decisions based on what we're afraid of. I regret that. Now I will say this, and I hope that you hear this loud and clear. I do not believe that addiction is, I do believe that addiction is a crime. Well, I'll get it right now in a minute. I believe that addiction is a disease, not a crime. However, I will always add the caveat that if that is the only way that we can get a hold of somebody to save their lives, then whatever it takes to get a person into treatment and recovery, we have to do it. Because there's one thing for sure, we don't recover if we're dead. So anyway, we made a huge mistake that evening. We made a huge mistake that evening. We would make so many mistakes, and that's one reason I'm here tonight. The main reason I'm here tonight is I hope that from the mistakes that we made, that you might learn something, that you might gain something in your journey with a loved one that may be addicted. So anyway, Casey wasn't living at home. He was living, like I said, in a house over by UC. And so we weren't seeing Casey very much except on the weekends. And he would only come home when he could present pretty well. So we knew he was using pot, but what we didn't know was that his pot use had expanded and progressed to other things like the pain pills and eventually to heroin. So it wasn't until Casey it was in February of 2002 that Casey called home one evening and he said, I'm in real trouble, Mom. I'm addicted to OxyContin. I said, well, Casey, I'll come and get you tonight. And he said, no, Mom, I promise I'll be home in the morning. And sure enough, he was home the next morning. And as soon as he hit the door, he said, where are we going, Mom? And I said, well, Casey, they won't let me call. You have to be the one that makes that phone call. Because you see, Casey knew that I had been trying to help him, that I had been doing all that I could to get help for him. But I was stymied every time I would call somewhere, every time I would call a professional anywhere. The message that I was getting over and over again was that Casey had to want to, he had to loosen up, and he had to hit bottom. And from the nodding heads around the room, I know that you all have heard that same mantra. What I know now is that that is a myth. I'll say that again, that is a myth. No one wants to be addicted. No one. If you have ever read any of the writings of someone who is addicted, the way they pour their heart out their heart and soul out in their writings. I wish I could brought one of the poems with me tonight. I mean, there would be no doubt in your mind that that person is tormented and does not, absolutely does not want to be doing what they're doing. Losing enough. You know, how much is enough? My office is in the Transitions Recovery Center for Men. It's called the Grateful Life Center. There are men there that have lost more than enough. They've lost their children, they've lost their wives, they've lost their jobs, they've lost their insurance, they've lost their homes, they've lost everything. And you know, one day I was doing class with them, and one of the things that one of the guys listed as a loss was self-respect. They've lost it all. The only thing they haven't lost is their life. And that's good, because as long as they have that, there's still hope. There's still hope for their recovery. And hitting bottom, what is bottom? What is bottom? For many, there is no bottom unless we raise that bottom. And that's what we have to do in order to help someone. You know, you would think that after someone overdosed and came around, they would say, oh my gosh, I'm not going to do that again. I don't want to die. But there are people that overdose not once, not twice, but for Casey it was 3 times. 3 times. And every time that he overdosed, at the hospital I was told on one occasion by a nurse, honey, he's still too young. He hasn't lost enough yet. And I looked at her and I said, what if he doesn't live to be old? I didn't know how prophetic those words were going to be, but shortly after that, Casey overdosed for the 3rd and final time. Now, when Casey overdosed, we wanted to donate his organs. We couldn't because he was an IV drug user. And so, you know, we thought, well, you know, we wanted Casey to live on. We wanted him to live on. And we thought that if we could donate organs, he could live on. I said the plan was much bigger than our plan, because Casey is living on in the lives of so many people that are now in recovery because of Casey's law. You know, I said when Casey died, I was a mom on a mission. I was like a loose cannon shooting off in all directions, hoping I would hit something. I didn't know what, I didn't know how, I just knew that I was going to do something to make a difference for other families, families like you all that are sitting in the room tonight. Because for us, there was no option. There was nothing that anyone could tell us except to have our son arrested. I did call the prosecuting attorney's office at one point, and what I was told was, well, you know, you can have Casey arrested. There are parents that do that, but I just want you to know that when you do, you're out of the picture, and whatever the court decides to do, that's what will happen. And that scared me. Again, I was being ruled by the fear of Casey just being locked up without getting any help. And I knew that incarceration was not the answer to his disease. You know, I would ask you all tonight, what other disease do you know of that they tell you must be punished before you get treatment?
None.
None. That's right. And so I backed off. I didn't have Casey arrested. And you know, really, I didn't have anything to have him arrested for, except for the fact, of course, that he was using. But Casey had never stolen from us. He'd never done any written checks on us or anything like that. So I didn't really have anything of that nature to have him arrested for. But of course, the use was definitely against the law. And certainly of harm to Casey, of danger to Casey. So anyway, I went to my state representative and I asked him if he would be willing to sponsor a bill that would allow parents, relatives, or friends to petition the court on behalf of someone who has a substance use disorder, regardless of age and without any criminal charges. Those 2 things were so important to me. Regardless of age, because Casey was over the age of 18, They said, well, you know, he's an adult. He can make his own decisions. Well, the problem is he wasn't capable of making a good decision for himself. And I'm sure Dr. Kalfas will talk more about this. You know, the prefrontal cortex isn't working. The pleasure center is working overtime. You've got nothing to put the brakes on. And a system that's saying, go, go, go. It is a brain thing. This is a brain disease. It's not a lack of moral character. It's not a matter of will. It's a matter of the brain and how the brain is now functioning or not functioning. And so my state representative was willing to sponsor this bill, introduce the bill, which he did in 2003. It did not make it out of committee, and so it was dead in the water that first year. And I thought, well, we'll go back the second year. And I know the people on the committee now. It was assigned to the House Health and Welfare Committee. It'll be easier. We'll get this passed in another year. When all along, people were telling me it was going to take at least 5 years for it to get passed. They said, Charlotte, you know, it usually takes 5 years. Don't be discouraged. Don't be disappointed. And I would say, okay, and I just kept going. And so the next year, I thought, well, we're a step ahead now. Wrong. They assigned it to the House Judiciary Committee. Whole new committee to learn, whole new committee to educate. And it died in committee. But luckily, we were able to amend it onto another bill that had passed the House and was in the Senate. And ultimately, it was passed in 2004. It became effective July the 13th of 2004. So since that time, there have been many young people, young and old, not just in all ages in between, that have been able to get into treatment and into recovery because of Casey. So as I said, the picture was much bigger. The plan was much bigger than what we imagined it would be, and I am so grateful for that. I know I'm running out of time, and I want to tell you just a few more things that I think are really, really important as a message to you all tonight. If you do not know who your representative and your senator is, get acquainted with them. It is in the state government. It is in Frankfurt where decisions are being made about prevention, treatment, and recovery resources for our state. We need to have a voice in Frankfurt, folks. And please, please get acquainted with your representative and your senator. Start making those phone calls and getting acquainted with them. Let them know what matters to you. Because after all, how do they get there? We elect them, right? And who do they work for when they get there? Us. And they truly are interested in what's important to us. So it's our responsibility. It's our responsibility to let them know what's important to us. And certainly what's important to all of us in this room tonight is prevention, treatment, and recovery resources. Because even with Casey's Law, if a person doesn't have any place to go, you know, it diminishes the effect of Casey's Law because we have to have places for people to go. I will tell you that right now in the legislature, and I just called today, there's an naloxone bill in the legislature now. And for those of you may have heard it called Narcan. It's the medication that's used to reverse an overdose. And this bill is going to expand the use of it so that doctors can prescribe it more and that they will be absolved of any kind of criminal charges, I guess is how I should say it, Dr. Kalfas. And also third parties like Good Samaritans could, and in fact it is called, a piece of it is called the Good Samaritan Law because it would allow people to, when they see someone overdosing, instead of like it said in the paper, and if you didn't see this, I hope that you will look online if you didn't get the paper today. But it will allow, instead of people to help someone that's overdosing, rather than drop them off at the fire department or the hospital and have the firemen look out and see a person laying in the driveway. So, but just a quick word, and I know I'm running out of time, I'm trying to talk fast. If you go to the website, www.lrc.ky.gov, that is the Kentucky Legislative homepage, or you can just Google Kentucky Legislative homepage. It is now in a free conference committee. It's the free conference committee report. That needs to be passed by both the House and the Senate. So if you make a call, if you choose to do that, you would need to ask for approval of the free conference committee report on House Bill 366. It now has a new number because it's in the House now. So if you want to talk to me more about that later, I will be glad to. There is on the side, there are links to toll-free numbers that you can call to leave a message for your legislator or the whole General Assembly. And when you call that number, it's 1-800-372-7181, a number that you need to memorize so that you have it anytime that you want to make that telephone call. It generates a green slip every time you call, and I have had legislators tell me they pay attention to the number of green slips they get. If they've got a stack of green slips like that, they're going to pay more attention to it than if they've just got a few in another stack. It really does matter. It really does matter that you call. It really does. I don't know if Dr. Kalpas or anybody else, I hope will talk about our heroin impact and response committee. I hope so, because that's a whole other thing. We're having a PAR meeting again on April the 3rd. That's a week from Wednesday at 6:30 at the Grateful Life Center again. That's People Advocating Recovery, a group that I've been with since the inception back in like 2003. And we now have a Northern Kentucky chapter that is up, and I hope will make a huge impact in this area to make a difference for everybody. And I'm really excited about that. And so I think that was all I was going to say. I know I'm out of time. Thank you for listening. And if you have any other questions, I'd be glad to talk with you afterwards.
If you came in late and you would like a couple index cards so that you can write questions down on it, we'd love that we can get them in your hands so that you can do that, or if you want to take notes or anything. Okay, Dr. Kalpas is here, so we'll go ahead and let him go.
I'm Dr. Mike Kalpas. I'm very sorry I'm late. What I like to say is, in the true spirit of a Greek tragedy, trying to avoid my fate of being late, I perpetuated my fate of being late because my excessive acceleration resulted in a speeding ticket. The amount of time I was late was just about the amount of time it took the officer to write my ticket. My apologies again for being late, so learned a lesson there. I just want to say what an honor. It's always an honor to speak anywhere behind Charlotte. I've known her for a number of years, and I just think if people responded to sorrow and grief in their life like this woman has, we wouldn't have a problem if the average person could respond like that. So, just taking the bull by the horns. Just a brief second about myself, so maybe I can give myself a little credibility about why I'm speaking. I'm just a family doc. I finished my training in '96 in Cincinnati, and I ended up in Falmouth just as a country family doctor the first few years, and by fate, God somehow directed me into the Drug and Alcohol Treatment Center, which really very quickly became my passion. I worked there until a couple of years ago when I switched practices and went to Fort Wright. But I still do quite a bit of addiction medicine. I'm board certified in addiction medicine. I had a reporter the other day in an interview ask me why it's important to have addiction medicine to be its own field. And my answer to that is that we need to keep developing treatment strategies. We need specialists that we can turn to. You know, when you go to see your family doctor for diabetes and they get to a point where they can't help you anymore, you need somebody to turn to, somebody that's up on the current, up on technology, up on new resources, somebody that can help you direct further. And that's why I think addiction medicine is important as a specialty. I'd like to talk for just a second to kind of maybe expand on a couple things that Charlotte said and go deeper. The one message that I would hope you hear out of what I'm saying is that there is a lot more to this heroin addiction problem than someone just simply having a moral shortcoming or a lack of willpower. Charlotte said these words a couple times, and I truly believe that this is a brain disease. Okay, and I'd like to talk about what happens a little bit and how it reaches the point of being a disease and what happens to it. If you think of how your brain works, your brain is this wonderfully designed biochemical computer, and it uses neurotransmitters or chemicals to communicate one area of the brain to the other. And these neurotransmitters will bind to receptors to cause an effect somewhere. And the analogy I like to use when I'm talking to a patient is I'll say, think of a receptor as like a lock on a door. And the drug is the key that goes in the lock. The key goes in the lock, turns, and something happens. When it comes to opiate drugs, and we use that word opiate, this means that any drug that acts similar to morphine. Morphine is a derivative of opium, which is from the poppy plant. Those two drugs have been around forever. Opium has been available for hundreds of years, if not thousands. Morphine has been able to be, it's a very simple chemical extraction. You get morphine out of opium, out of the sludge from the poppy seed plant. It's only been in the last 100 to 150 years that our chemists have gotten really smart and started playing around with that molecule. And one of the things they did as far back as probably the 1870s is they figured if they could stick a couple acetyl groups into a couple certain places, which is not a very difficult chemical maneuver, we could create this really neat drug called heroin. And any drug that sort of has the effect of this class of drugs is called an opiate. Opiates will hit several different types of locks or receptors in your brain, but the most common one is, or the most important one for what we're talking about, is the mu receptor, like the Greek letter mu. When that mu receptor gets stimulated, that's what Charlotte was talking about when she said this, that pleasure center is out of control. This intense feeling of euphoria, like everything's well with the universe, that you're impenetrable, that you're omnipotent. You just feel 10 feet tall and strong as an ox, and you just feel great, everything's wonderful. For some people, there's even a genetic predisposition to that receptor being stimulated. So when they run into heroin or any other opiate, it's even 10 or 100 times worse than it is for the average person. The more you start to do that sometimes is the basis for the kind of love at first sight phenomenon you'll see with heroin addiction. Some people literally the first time they get it, their brain is like, wow, this is what I've been waiting for my whole life. And their brain just latches onto that and it focuses on nothing but that. The more you continue to use it, the more of those receptors you make. It becomes obvious, or it becomes evident to your brain after a while that the only limitation on how high I'm going to get, how much pleasure I'm going to get, is how many mu receptors I have to fill. Because he's going to fill them all. So it keeps making more and more and more. And that's called, in neurochemistry, it's called upregulation of receptors. You keep making more and more mu receptors. So an addicted person is going to have maybe thousands of times the receptor load of mu receptors than a non-addicted person. Remember I said your brain's a biochemical computer. It's got to run balanced. The more of those receptors you make, they can't stand to sit empty. So they have to be filled or the brain's imbalanced. So you have a brain that, just like a tire that's out of balance, is not working properly. The closest they can come to functioning normally is if all those receptors are being filled and stimulated. So they run, basically their life becomes, how am I going to fill my mu receptors today? That's the most important thing to their existence, period. And I want to make a preface, but I never ever excuse what people do. The crimes people commit, we don't just excuse it because they couldn't help it. That's not the point. If someone steals, that's one thing. But we're talking about folks that sometimes their only crime is having in their possession that which they're addicted to. So anyway, I probably got a little off target there, but I don't want to paint this picture like, oh, they just can't help it, so poor helpless things. If they're committing crimes with it, that society needs to address that. It's a separate issue. But I'm just talking about a brain that's not functioning appropriately, that's not functioning right, it's out of balance. Probably the first studies that were done actually treating this as a scientific problem, because prior to that, these were just pushed aside. I mean, we think heroin addiction is new. I mean, they knew about it in the early 20th century, the 20s, the 30s, the 40s. It was there. The first guy to kind of treat this as a disease was the Dr. Rice back in the 50s. And his actual initial conclusion was that this is an incurable brain disease. That the person that has this brain disease can't be helped, is going to die from this disease eventually. And he decided that the best thing to do for these folks would be to try to give them some semblance of a normal life, close to a normal life. We can't give them back their life, but we can try to come close. So let's come up with something that we can give them that will make them function normally as we can be given under medical supervision, will satisfy those mu receptors in the brain so that they're not empty and screaming and imbalanced, but a doctor or nurse actually giving the medication or the drug so that they function normally. So what he needed was a drug that was easy to manufacture, that was inexpensive, had a very long half-life so that it would last in your nervous system for a long time. And Dr. Rice came up with the idea of methadone, because methadone had been around for about 20 years at that point and could be made cheaply and lasted a long time. I mean, there's some inherent problems with methadone as well, but for some people it is truly a lifesaver. Dr. Rice was very correct about some aspects of his research, but he was incorrect about some things. What we know about brain chemistry is these folks can be helped, just as those receptors upregulated and got to a point where there was a heavy receptor load in their brain. Over time, they can be stabilized and that receptor load can be decreased. You can actually successfully wean someone off of methadone. It's difficult, but it can be done. There is a possibility of returning to normal brain function, but it's difficult. And like Charlotte said, one of our most frustrating, daunting tasks sometimes is to keep them alive long enough for that to happen. So I hope, at least with what I've said so far, that there's some understanding of what this stuff does to your brain. It gets into your brain, it causes you to, it hits your pleasure center. Part of your brain that it hits is the limbic system, which is where pleasure and emotions and instincts lie. So it's below conscious control, and it takes control of a brain there. And when it's not there to stimulate that brain, the brain just functions completely abnormally on a subconscious level. And one of the things Casey's law was meant to do is recognize that I cringe every time when I hear Charlotte speak and she says that part where, well, he's over 18, he can do what he wants. No, he can't. Someone who's addicted to this stuff stops developing emotionally the moment they got hooked on it. If you have a 25-year-old that's addicted to heroin, their response to emotional stress is that of a 16-year-old, usually. Because their response to stressful situations in their life has been to get numb and block it out. They've developed no coping skills, they don't know how to function, they don't know how to do anything, and they got to be taught that. That's part of their treatment. So just saying, oh, well, they're an adult, they can do what they want, well, we buried a lot of those. So, this law helps us to recognize that sometimes they need a little more, someone that loves them, helping them take control of their life to save it. What she mentioned about the naloxone or Narcan, Narcan is a reversal agent. And one of the problems now is if you come across someone who's down, someone who's overdosed. Okay, you hit 911 if you're lucky. 911 gets there in 4 or 5 minutes, maybe more. And they assess the situation, they get an IV line, and they give Narcan. Wouldn't it be great if, that first responder who maybe is a police officer or someone else, had in their cruiser a nose spray that they could spray in this individual's nose to revive them faster? That's what the Narcan is, the nasal Narcan. That's what we want produced. We want to get that out into the public where it can save lives. Charlotte mentioned our impact committee, impact and treatment committee, and we sat down and came up with our list of priorities. The first priority was stop the dying, was harm reduction, stop the death. And we really felt that that was the first thing we were going to, as a group, advocate. Get this passed. This is a prescription drug. And the biggest barrier to this is, right now a doctor has to write a prescription. Writing that prescription means that, if it's misused in some way, it's hard to misuse this drug, but somebody could complain the doctor gave the script when they shouldn't, and blah, 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 and there could be all these I don't know how you could really misuse this particular drug. I mean, if you're overdosed on a narcotic, it reverses it. If you're not, it's not going to do anything to you. But nonetheless, it's a prescription drug that requires a doctor to write a prescription. Wouldn't it be nice if it were more readily available? We could hand it out, you know, mass in a mass way, so that it's in the public and people have this available to them, like you would an EpiPen for an allergic reaction. You see a person down, you know, especially if you know they're a drug user, you spray this in their nose, you might save their life. That person now might live long enough to get better and beat this disease. That might be the precipitating event that makes that person say, I want help. I almost died yesterday, I want help. I don't know how many people I've seen get clean because they came to me and said, I almost died. You know, and that almost died is what makes them get sober a lot of times. Not always, unfortunately, but always. We want that, you know, my dream for it, I would like to see it, you know, wherever there's an AED in public, you know, where they have those defibrillators you put on people. I'd like to see one of those in the pack with that, you know, in public places and police cruisers, and so that an officer whose seat finds a young person out isn't helpless waiting for the paramedics to get there to revive somebody. We've lost 4 or 5 minutes of time when that person, you know, their brain is without oxygen. If you even save them at that point, they might be suffering brain damage. So that's really what we're asking for from our state legislators, is to remove some of the prescription restrictions on this drug so that we can get it out there. And one of the arguments I've heard about this is, doesn't that encourage people to use drugs? Well, you've given the, I mean, that's what some of you may be thinking. I don't know if anybody's written that on their card. Well, isn't having this stuff out there going to just encourage people to use more? The answer is no. I've been treating addicted people for 16 years. I have yet to see anyone that says, my motive, or the drugs that I use are in any way related to whether I think I'm going to overdose or not. Well, I'm not going to shoot that up because I don't think I'm going to. I think I might overdose. I'm not going to do that. You know. So if that's not the case, if they're not using, if they're not refraining from use because they're afraid of overdosing, then giving them an antidote for an overdose is not going to make them more likely to shoot up. Am I making sense? That's not a valid argument. So, although I've heard some very articulate people say that in different ways. That shouldn't be a barrier. There really is no harm to this drug being out there and being mass available. It's going to, you know, it's only going to help the problem. The next thing we need to do is we need treatment facilities. We need places where they can go. Detox alone, I'm just going to be blunt, and I hope, because sometimes this is all that's available. Putting someone in a detox bed for a week or 10 days until they stop withdrawing, and then sending them to an outpatient counselor afterward, less than 5% are still clean in 6 months. Okay? If I had a cure for cancer, or treatment for cancer, that had a 5% success rate, I'd look for something else, wouldn't I? You know, and that can't be the mainstay of our treatment. So there has to be other things, and there are modalities out there. One of the things we need to get past, I think, as a society, is this aversion that we have to medication-assisted treatment. You know, every time someone mentions the word methadone or Suboxone, negative images are conjured up about people abusing it and misusing it and redirecting it. Well, the fact is that if I take someone and maintain them on Suboxone and put them in a treatment program with a counselor, I can get 50 to 60% remission rates. That still stinks, but at least it's 50 or 60% instead of 5, right? Methadone clinics that are run appropriately and are well run and are regulated, and patients, and we can have a whole other talk in the back sometime about what I think the appropriate running of a clinic is, but appropriately run methadone clinics save lives. And sometimes those lives are saved until they get the gumption to do better, take it the next step. But that they can be helpful. In the past, whenever anyone talks about opening a methadone clinic in northern Kentucky, there's an immediate public rally, just like this one, where we shoot it down because we don't want that stuff in our neighborhood, and we don't want these people in our neighborhood. They're already there. They're pulling into the gas stations where you're gassing up to shoot up before they go home, or they're pulling into bathrooms like the 22-year-old girl that I know that was in a bathroom of a gas station 2 weeks ago, and when the staff didn't see her come out, they broke the door down and she was dead from an overdose in there. You know, they're all over the community. There are kids, there are so saying we don't want this in our neighborhood, we don't want our people, I'm sorry, I'm gonna get off my soapbox because I get on that tangent, but that's really what we need to do as a community, is be supportive of treatment. Our impact committee is dedicated to, like I said, our first step was harm reduction. How do we do what we can to stop the dying, stop the overdosing, and now we need to turn our focus to what do we do to treat them. And we really need to build an infrastructure, and there are some things coming, not soon enough, but we really need to. And I don't have all the answers for that. I can tell you what I think. There's another medication that I use quite frequently. It's an injectable opiate blocker. They can see me once a month. They can get a shot that limits the craving, and it also keeps, if they get the shot, it makes it very, very difficult for them to get high over top of it. I can give that shot once, and that's great. You know they got it. You know, they're coming, they're getting the shot. They get no high effects off of it. It's a complete blocker. It's like it's like another form of that naloxone. It's a complete blocker. When they come off of it, they have no withdrawal from it. But I got to have them opiate free for a week before I can give it. It means I have to have a detox unit. I can put them in for 7 days, keep them clean, give them that shot when they leave the door, because before they go out the door. Because if they go out the door and they've been detoxed for 7 days, 2/3 of them are going right to a heroin dealer. And they're high within 20 minutes of leaving the unit. I got to give that shot before they leave the unit. And I got to have somewhere to do it. So those are the barriers that we're facing, and I would ask everybody to pray about that. You know, we need, as a community, these are the things I think we need to be focusing on, and at least that there's a group of like-minded people that are finally coming together to deal with that. And I hope, as you all hear this, your various talents and whatnot, you know, you just, everybody in this room's got a talent somewhere, and I hope it just sticks in your heart to throw yourself into this, whatever you can do to help. But anyway, I think I rambled just a little bit. Is it? Are we doing questions at the end? Okay.
Thank you.
Hello, my name is Rich Whitford. I work for the city of Fort Thomas. I've been a police officer for 21 years. I oversee the detective office and the crime scene. About the summer of 2011, we started seeing a sharp spike in crime. Car thefts, car being broken into, stealing the cars, breaking into houses. What we try to do is everybody we catch, we try to talk to them afterwards, try to get in their mind, trying to figure out why. How can we stop this? Why they might have done this. Around that time, we started hearing about heroin. And I heard about it in the 70s, seen it on movies, that was about it. I remember crack cocaine had an epidemic in the 80s, and we went through methadone. We tried to combat everything that came around. We're always trying to catch up. But this is something I've never seen. Never seen anything like this. Everybody we started talking to, they want to get off of it. They want to get off it, they can't. I've never seen anything like this. In my career, about what I've seen, what I've read, what I've studied, that's why I started this committee, got on it. Because it's killing a whole generation. And it's something we need to do. One of the best things we've done is gone to the media, tried to get the information out. I want to scare the hell out of everybody. For what I see every day when I go to a family that has to bury a loved one. That's what we need to get out there. And thank the Lord that the media is helping us. The deaths from 1998 to 2009 in Campbell County, we had 2 heroin overdoses. From 1998 to 2009. 2010, we saw 5. 2011, we saw 12. And last year in 2012, we saw 38. That's the increase, that's what we're facing. And not only the people are dying, but the people that have been saved at the hospital that have trouble just surviving. And the impact and the crisis that's on the family is overwhelming. And it's not going to stop until we do something about it. Just talking about it, getting out here to media, this poor lady, I love her. What she's gone through and how she's helping everybody. This is what we need to do. Got to get the law. There's got to be something. We kept saying, what are we going to do? When I talk to these people, they say, I don't want to be on this. I don't. Some of the stories I heard absolutely tear your heart out. 17-year-old girl has lost 2 of her children, and she said she tried to quit. She thought she was going to die, that she is not strong enough, she cannot do it by herself. She's prostituting, she's doing anything she can, she's on the run because she can't quit, and she wants to. That's the stories we hear. The people that don't want to quit, I'll find a room to put them in a timeout for a long time, hopefully. But the ones that want to get help, the ones that need the help, they're asking for help. For the last year and a half, we don't know what to do. That's what we're starting to talk, transitions. We're starting to push them towards them, people that want help. That's what we're doing, having these town hall meetings. I'm here on my own, I believe in this. I believe in these people, we need to do something. That's why we're here, asking for the people and help and everything else, okay? The media, they're helping us. You know, we're trying to sell the paper today. What a timing to put this out. And they know the crisis with all the deaths. And last year in the summer, in 3 months in the state of Kentucky, there was 52 deaths for heroin. Northern Kentucky had 80% of those deaths. Our 3 little counties, 80% of all the deaths for 120 counties in the state. Right there says it all. And what are we going to do? You know, do we put them in jail? No. It's a sickness. And it's something we need to do with the laws, with the treatment, with the facilities. These people don't want help, we got to get them help. We're trying to figure out how much his impact is on the residents. You know, how much theft is occurring because of heroin. Louisville just did a study, they said 80% of all their property crimes is heroin related. The big city of Louisville, all the property crimes, think about that, 80% is because of one drug. If we can get those people help, we could try to stop it. It'd be nice to curb 80% of all crimes in a little city like Louisville. And that's all throughout the state. And it's moving throughout the state now. Started with the opiates, now they can't get them because of pill mills being shut down. And this is what we're dealing with. Something we're going to have to fight and combat and try to do the next steps to get out in front of this. And that's where we are now. You know, the new laws are going in right now. We're trying to go after the drug dealers when there's a death involved. It's going to be tough, there's no doubt about it. You know, they cross that little pond called the Ohio River and they go over there, that's where all the drugs are being bought. No doubt in my mind what we're seeing, what we're hearing. So if we have to go across the state lines to try to get the drug dealers over there, do our investigation and prosecute, it's going to be tough, but we will do it. We will get out, we will put a couple in jail, we will try and we'll make a big media circus out of this to try to let it know you cannot do this. That's how we're going to get the media out there. They're going to assist us in putting this out there and putting these people in jail. You know, it's easy money, that's all it is. Easy money. So how you combat it? Try to do our investigations, try to work a good case and put them in jail and let everybody know. That's how we're going to do it. Get them.
My name is Michelle Kritzkamp. I'm actually an emergency room nurse, and I've been at St. Elizabeth since 1995. And when this whole task force started, when Dr. Engel called and said, we need some data, we need to know what you're seeing in your emergency rooms. And I'm like, well, I know they're up, but I had no idea how much, and so I started doing data. Well, I looked at 12, and I'm like, well, that's high, but let me look. And then I looked at 11 and kind of compared it to 12, and it was alarming on the number of overdoses that we've seen. And I've already looked at January and February of 2013, and I know you won't be surprised that the bar graph continues to go on an upward trend. It's passionate for me just because of an emergency room nurse. It's hard to tell a family that their loved one has died. And these young kids and parents who don't even know yet that they might be addicted, or maybe they know and they're still in denial. It's been hard on my staff to see the number of alarming patients. There needs to be a lot of education to the nursing community as well on how to take care of these patients. You know, listening to Charlotte's story, you know, my passion is to educate the nurses that are in our facilities at St. Elizabeth to try to get them to understand, be more compassionate, know what resources are available, because like Charlotte was saying, you know, you come in and I don't want to be that nurse that Charlotte met the first time, and I hope my nurses don't ever act like that, because we are compassionate. I think we really are starting to see the what is happening in our communities, and we want to help too. I mean, we're here to take care of patients. We do not want to see them on the other end either, and they have to tell their loved ones that they're not going to be here. So we're doing, my passion on being part of this mission is to do a lot of education with nurses, get them to understand, to be compassionate, and to understand this is a disease. I just did a talk for critical care nurses a couple weeks ago. And, you know, Charlotte's right. Some people might not hit rock bottom yet. Their friends are the ones who drop them off in my emergency room, blue and not breathing, and pull their car away. They don't have family, they don't have a support system. But if you're that compassionate nurse who says, you know what, there is still hope for you, there is this available and this available, and you're worth something, then maybe I'm the first person that they think that they can actually get some help. So that's important. And I want my nurses to care that much.
My name is Chuck Washburn. I'm the System Director for Behavioral Health at St. Elizabeth Healthcare. I'm a nurse by profession. I've been a nurse involved in behavioral health, chemical dependency for 30 years. I've been at St. Elizabeth since June of last year. So I wanted to talk to you, first of all, I wanted to say how excited I am to see a community as interested and as mobilized as I see here in Northern Kentucky. I've never seen anything like this in my 30 years of practice, and I practiced in very large cities, small towns, never have seen a community as mobilized like this one is about this issue. So that's very gratifying to see. Wanted to explain to you or just talk to you a little bit about some of the things that St. Elizabeth is doing to respond to what is obviously a growing epidemic. First of all, we've improved our outpatient services. We know, the data tells us that 60 to 80% of people who have a chemical dependency problem also have some other psychiatric diagnosis or mental health illness. And we also know that the best way to treat that is not to try to figure out what came first, the chemical dependency or the behavioral health problem, but to take care of both of those things at the same time. And so what we have now, what we offer now at our Edgewood campus at the outpatient center is what's called dual diagnosis. In other words, you treat both the behavioral health issue and the chemical dependency issue simultaneously. We offer those services for adults and for adolescents. And we offer what we call an intensive outpatient program, which is 9 hours a week, 3 hours a day, 3 days a week. So that's a tremendous improvement in terms of the services we offer. Evidence-based treatment that is proven to work. The other thing that we're doing in conjunction with St. Elizabeth physicians is we're recruiting additional physicians who can offer medical assisted treatment, because we also know, the evidence tells us, as Dr. Kelf has said, that that's the most effective treatment, and we know that we don't have enough providers for that in our community. So we're working hard at recruiting new physicians to come into the community who want to offer that treatment, and we're also recruiting within St. Elizabeth Physicians itself individuals who want to get the appropriate training so that they can offer those services. And those services are also going to be offered at our Edgewood campus. Third initiative we have is that we know, because we have the data, that we have hundreds of people that come through our system every month with a chemical dependency issue of one kind or another. And so what we're doing is we're working hard to identify those people, whether they come to the emergency room and go back home or whether they're admitted into the hospital. We identify those people and we make sure that those people are contacted by a chemical dependency counselor to help them with their issue. If they want to help, we can point them in the right direction in terms of how we can get them the help they need. We know that when people come into the hospital, they're in crisis, and many times that's an opportunity that they're willing to seek help. And so we're trying to find those people when they're vulnerable so that we can get them the help they need. So that's the third initiative. And then finally, what we've done is we've been awarded a certificate of need for 58 chemical dependency beds for Northern Kentucky. So it's our intention to open up those 58 chemical dependency beds at the old North Campus in Covington. So we are hopeful that sometime next year, after we've made the appropriate renovations and done the appropriate preparation, that we'll have 58 additional treatment beds for individuals in northern Kentucky.
And like Chuck was saying, we're working really hard with chemical dependencies. He allowed us to do a pilot program last month, which is very underutilized, so we're working hard on educating the nurses on the need for that. So if a patient comes into the emergency room and we diagnose them as like a heroin overdose, then we can call and leave a number on the chemical dependency line, and they will follow up with those patients the next day, because that's when we can get a hold of them. Like Dr. Kalfa says, those were the, I almost died yesterday in your office the next day. And so we really are trying to improve on our process in the emergency departments to work with Chuck and his team in chemical dependency to make sure that those get more, we get more awareness out to the nursing staff, so we can capture those and take that opportunity of the chemical dependency team that he has.
I would just kind of add to that too. What Chuck said about watching the community in Northern Kentucky respond to this. I mean, I think that's just part of what makes America great to begin with, is our mentality. Everybody's got value. Everybody's worth something. Everybody's salvageable. When I look around the world, and even in this country, you go back a few decades, and this was a problem. It's like, well, they're an addict. Shove them aside. You look at other parts of the world, you look at the Netherlands, their response to this was, let's just give them heroin, then they won't steal from us. And, they'll probably go out and kill themselves with it, but at least our conscience is settled, Very few places in the world are they really actively looking to treat people with this disease. It's not humanitarian to do that. Americans, we're different. We believe that everybody has value, everybody's salvageable. We take pride in the fact that the person who looks like the biggest underdog can be the biggest winner. That's just an American thing, we're proud of that, and I think that's what it's going to take to beat this. That's why I think the cure for this is going to start amongst Americans like ourselves, because we have what it takes to do it.
Well, I think too, talking about it, this is something that has been hidden for so long. And I know that we could have filled this building many times over tonight. Because I know for a fact everybody I talk to, regardless of where I am or what I'm doing, has a story to tell. It has been because of the shame, stigma, and discrimination that has surrounded this disease for such a long time that people haven't talked about it, and that's has contributed to the many losses that we've had to this disease. I had a mom call me not too long ago, and she said, I think we're at the tipping point because enough people have died. Is that not tragic? Oh my gosh. Of course, I thought when Casey died, that was enough. That was more than enough for me. And when Dr. Engel showed up and we started this heroin impact committee, and we had like 35 people in the room, I told him, I've been waiting for you guys to show up for 10 years.
She did too. It's the first thing she said.
It's the first thing I said. For 10 years, I've been waiting for you to show up. And I am so very grateful that they did. And I am so very grateful for you all tonight. You cannot know what it does for me to see people actually step up and speak out. Because, as Dr. Kalfa said, these are people who are worthy. They are worthy of treatment as much as any other person out there with any other disease. I never thought that Casey would die from a socially unacceptable disease, but he did. He did. I tell people all the time, my husband has multiple myeloma. It's not a curable cancer, it's treatable but not curable, just like addiction. Within 6 months, he was in a clinical trial, he had had a stem cell transplant, and he was a new man. And we celebrated 4 years of remission for him in January. For Casey, it was a totally different story. We found out he was addicted. 6 months later, we were burying him. That should not be. And I would challenge you all to go forth from this place tonight and talk about this. Talk about it. Because think about what happened. I said, I'm old enough to remember when cancer was whispered. It was the C word. You didn't talk about cancer. For those young people in the room, you may think that's just, insane that people wouldn't talk about cancer, because we hear about cancer all the time now. But what happened was that more and more families were affected by cancer, so more and more people were talking about cancer. And then what happened? Well, we had telethons, and we had walkathons, and we had more money for research dollars. And now we've got more people living with cancer than dying from cancer. That's what I want for addiction, folks. More people living with the disease than dying from the disease. There is no reason why that can't happen. As Dr. Kalfas said, we can get to 60% success rate, remission, but there's no reason why we can't get closer to 100%. Have you been seeing these cancer PSAs on TV where they're in the train stations, or they're out and they're telling people to speak up, and I don't know exactly how it goes, but Jim and I were watching Oprah one day, and she had on all these people that were cancer survivors, and they were standing up clapping, and I said, that's what I want for addiction. My gosh, these are people that are working harder at surviving. I mean, if you're working the 12 steps of AA, my gosh, working on being a better person every day of your life, plus all the struggles that you face with the disease and the way that you're looked at when you say that you're addicted. It's like a woman I talked to in Texas. She said, if I told somebody that my son had cancer, I'd have a dining room full of casseroles. She said, it's a whole different story when I tell people that my son's a heroin addict. You don't get that kind of sympathy. But it's up to us. It's up to us to educate people. And it's going to take all of us. I said when I started speaking, I spoke for two reasons: raise awareness about the disease of addiction and inspire other people to advocacy. Because I knew my life on this planet, I don't know how many more years I have, but I want to know that when I leave this earth, that there's going to be people that are going to come behind me to continue to carry the message. And we can do it. We can do it. The Mothers of MAD did it. AIDS. I mean, we've got other examples we can follow.
One of the most frustrating things I found early on was this attitude. Early on in treating this was the attitude that, these people did this to themselves. They made bad choices. I ran into that a lot. Where do we draw that's just such an unacceptable answer. Where do you draw the line with that? And if I offend anyone with what I say next, I apologize up front. But if you have lung cancer, chances are you got it from smoking. You made a bad choice. Would you tell that lung cancer patient, well, you did that yourself, so we're not going to treat you. We're not going to research you. We're not going to, I'm overweight. I obviously don't eat the best in the world. If I have a heart attack, are you going to let me die because I ate too many McDonald's? No. You're going to put a stent in or whatever it takes, bypass me. Just because a bad choice that you made at some point in your life shouldn't preclude your value as a human being to deserve treatment. And that's the biggest battle we're facing with this, I think.
Okay, I think right now what we'd like to do is go ahead and open it up to questions and answers. Are you all right with that? Okay, so if anybody has a card that you either want to stand up and read it or you want us to collect it, you can do that. And you can. And having said that, just kind of looking in the room, I would like to thank Mayor Ashford for coming out tonight and supporting us, and I would like to thank Mr. Franzen for coming out and supporting us tonight too. Thank you. And anybody else that I'm missing? We have some city council members over here. We're very glad that you're here. And our fire chief is here. So thank you very much for coming out.
And Linda, I didn't say anything, but
Please here. If anybody wants any literature, we have a whole table full of literature back here that you are more than welcome to get. And if you're curious about how to get involved with the coalition, please get a report. You can contact, or you can talk to any of us sitting over here.
I did it.
But now go ahead and do some questions and answers.
When we go to our meetings, we just let her talk. Now you know why. Hey, Coach.
Absolutely.
me, you. Oh.
Who's that?
You want me to go ahead with the first one, or?
Please. Yeah,
I'll
go
start down here. Okay, this question is, how does a recovering addict get the opiate blocker that Dr. Kalfas mentioned? Can a family doctor prescribe it? Without giving an advertisement for the drug is called Vivitrol, Vivitrol, and it's basically, it's a non-scheduled, it's a prescription drug, but it's a non-scheduled drug. What a doctor has to do is they have to be comfortable giving it. It's an injection you have to mix up. You put the components together right before you give it. It's given by a doctor or nurse in a medical setting. It's not something we send you home with to do on your own. But any doctor can do it. We just need more doctors willing to do it. And I'll just leave it at that. We need people to step up, be willing to do it. I probably, in a course of a month, probably give about 25 of them a month in my office. And that's pitiful, because there's probably about another 3,000 people that could benefit from it. It also does work for alcoholism, actually. What it does is it blocks that mu receptor, which blocking the mu receptor down the road, I won't bore you with a biochemistry lecture, but it has an effect of limiting the craving, which kind of helps balance the brain chemistry while this person's healing, while their brain's healing. Healing usually, after you stop using drugs, usually takes anywhere from about 6 months to a year and a half for the brain chemistry to get back to normal. And this allows that brain chemistry to return to normal without constant craving, without the side effects of irritability, not being able to focus, pay attention, etc. And it's also got the added benefit of being an insurance policy, because if you try to use, and this is in your system, you can't, it's hard, it's not impossible, but it's difficult to get around the blockade. So, that one of the things that really hurts an opiate addicted person is they've been clean for a while, and the first time they use, it's like when you're on your computer and you haven't touched your computer for a while and the screen goes dark and you jiggle the mouse and the whole thing comes back up again. The first time they use after they've been abstinent for a while, it's like that computer screen just flipping back. It's all right back where it was the first time they use. And this is more of an insurance, like they use something and they're like, well, gee, I wasted my time and money on that one. Even somebody that slips up in their recovery is more likely to get back on the bandwagon and get themselves back on track. So it's helpful there as well. So
How long does it last?
how long does it last? You get the shot once a month. And the studies that were done on the drug were 6-month studies. There's really no end point as far as I've had people take it as short as 6 months and as long as 2.5 years. But I've seen it work, so I've seen some good results with it.
Are there like side effects or something? Is that why?
Probably the biggest side effect that I've dealt with is it's a big shot. It's like 4.5 milliliters. So I see a few nurses in the crowd. That's a big shot. It's like getting 2 penicillin shots in one spot. But and I've seen, out of the 600 or 700 shots I've given, I've seen 3 local abscesses. When I give it with betadine. Under sterile prep, make sure that it's at room temperature for an hour. There's some things you can do to minimize that. But even then, you'll still get one occasionally. And these aren't life-threatening things, but they're annoying because you have to go and have an incision about that big made and drain it. The shot, it's interesting. I thought the fact that it was a shot would be a barrier to a lot of people. And most people go, ooh, that hurt. And they go on and they come back next month and, show me the other side, get the next one. So the pain of the fear of the pain of the shot hasn't stopped anybody, in my experience, from taking it. So. It's interesting. The drug that's in that shot is a drug called naltrexone, naltrexone is actually an oral pill. It was designed to be like that Narcan, the naloxone we were talking about a minute ago. And actually, there have been some trials where the legal system has mandated people to take the pill. The shot has only been approved for opiate dependency for about 1.5 years. So it's a relatively new thing. It was approved for alcoholism for 5 years before that. But the oral pill for naltrexone has been around for about 20 years. I think there was a huge study done in the 90s in Cook County where the courts actually, as a as a condition of early probation for some people, gave them the pill. If they reported, they took the pill, they showed they'd been taking it, and they did get some results. I mean, one of the big things, like anything else, who's going to pay for it? I made this shot sound great, but I'll be honest with you. The off-the-shelf price is about $1,100. Yeah. But you can get it for about $600 if you know where to go. So it's not inexpensive, and I'm sorry to say that. I wish it was cheap. The pill form of it costs about $150 to $200 a month. The problem is the person quickly learns, if I want to get high today, I won't take the pill today. It's much more safety, and there's some more side effects like nausea and liver damage when you take the pill, because you have to take more of it. Whereas the shot, they're getting it. They came in, they got the shot. You know what they're getting. What I'm hoping is the cost of the drug will come down, and maybe it's something that down the road the court system can make a deal with the drug company to buy it in mass quantities and get it cheaper or something like that. Insurance usually pays very well for it. If it's $1,100, the patient's cost is usually around $100, and the drug company will usually waive that. So someone with insurance, it usually doesn't cost anything. Or if it does, it's very little.
But the problem we're seeing is most of them don't have insurance.
Right.
So that's what we're facing. If you look at an addict who might go out and steal 3-4 times a night, how much is he costing the community and his neighborhood? And that's what we're trying to correlate.
Right.
If he's spending it every year, he's stealing $200,000 worth of items, putting people at risk. Is it worth him to treat him for that?
And the time to jail him, and the time to take him through the court system 5 or 6 times. And
what's the cost of it? That's
Right.
what we're
one case of endocarditis. Does anybody know what endocarditis is? It's when you shoot up and you inject bacteria into your bloodstream. And those bacteria settle off on a heart valve and cause a vegetation. And that vegetation can break away and go anywhere in your body. It can go to your brain, cause a stroke. And the only cure for that at that point is 6 weeks of antibiotics and having your chest cracked and an artificial valve put in. One of those usually costs, a couple $100,000 in hospital bills by the time they're done? And we're seeing several of them now. So if we're going to start counting costs here, let's figure it all in.
I'm a registered nurse, and that's the aspect, I guess, I'm kind of glad you guys are starting the task force, because I'm seeing an increase in young patients who have the endocarditis, the vegetation growing on their heart valves. They're coming in, of course they don't have a problem, they stopped using, but that's not the case. And what's frustrating for me is we're seeing these people. The one young guy had pneumonia from the vegetation breaking off and going into his lungs. So the dilemma was, we can't send him home for IV antibiotics because he's going to abuse. Then we have to pay, because he doesn't have insurance. Needless to say, he has 6 children that, and he doesn't have a job.
Yeah.
So you look at all these aspects, and it's the same thing, and I stop and I think, well, how much are we paying just for this one person? And then we even had another case where the gentleman, he was fairly young, his girlfriend brought in and injected him and he cardiac arrested and died. We would have been, of course, they've always had multiple other diagnoses, pain medicine, or pain, chronic pain, and they're on narcotics there. Had the housekeeper not have found the syringe and the toilet paper holder in the bathroom, we would have been held liable. So, I see all these things, I see more young people, and I was like, well, how are you sending him home just with antibiotics? He's going to need to have, a valve replacement. And we're like, no, this is what we're doing. And I was just like, to me, it's really sad, and at the same time, I feel like I'm losing compassion because I don't see where treatment is being done to help.
And the evil that perpetrates this plague on our society wants us to do that. It wants us to get frustrated. It wants us to give up. It wants us to quit caring. And we can't do that. That's not an acceptable answer.
Let's talk about the young. One of what we're seeing is one study we have is 8 to 10% of our high school children are on heroin. 9th graders to seniors, 8 to 10%. Think about that. That's unbelievable.
My name is Mike Christian, and she is a recovering heroin addict. if she can come and speak to kids at school to let them know what is going on and how it happened. So I'm going to let her take the floor and tell her her story.
I love you.
Hello, I'm Kristen Hardy. I am a recovering heroin addict. I got knee surgery in 2001, I think, and I got hooked on painkillers. And once the doctor quit prescribing me painkillers, that's when I got introduced to heroin. It was easy to get to, and it took away the pain. And like the doctor was saying, that first shot, you know, I don't want to get too graphic, but putting that needle in my arm, I fell in love. You know, I never loved before now.
Be strong. You're doing good.
That's right.
You're here.
But that was in 07, I started using heroin. And I went to rehab and almost made it a year. And I rushed again. Thought someone found me downtown Cincinnati dead in the bathroom, and they gave me that.
Narcan.
Yeah, they brought me back to life. And this was back in the end of May, so I almost got a year again home. But and so I was talking to her. Reach out to younger people in the schools and have recovering addicts talk to kids, not just police officers and other things.
I'm with you.
You know, telling my story and maybe save others. And that's been the best academic around here. And, you know, I'm alive and I'm proof that you can't beat this.
Yes, you can. I want to ask. I want to ask a favor of you. I would like to ask a favor of you. When people don't want to hear what you have to say, and when they act disinterested and they want to tell you no, I want you to be like this lady down here on the end who didn't. I want to be honest with the people in this room. I was one of the people that told her no. I was medical director of the unit where her son went. I was one of the people that said, you know what, he's going to have to want to quit. Okay? And you can change people's attitudes and their minds. And I want you to be like her and not take no for an answer. Okay?
They say women who shoot heroin are most likely to die. And I just want to speak and get it out there that you can beat it. You know, you can beat this addiction because heroin is the worst drug out there right now. And I'm here today. You know, I got a great family, great friends, and you can't do it. You know, it's, you either want to use or you want to live a sober life, and I want to live a sober life.
Amen.
And glad I can still kind of talk. I think we should have, I know painkillers is another bad thing. And we need to get something going about that. Like, you know, older elderlies have pain pills in their cabinets. I think we need to get something together where they can empty out their cabinets and we can, you know, like at the high school, have people bring their old prescriptions that don't.
We have that.
We're getting more. Actually, the Campbell County Drug-Free Alliance is organizing a take-back day, and we've used some of our grant funding to supply some more drop boxes where anyone can come and dispose of their prescription drugs. And several
questions?
Fort Thomas, we're getting one in Silver Grove, another one in Bellevue.
Out here in Campbell County.
Campbell County Police Station too.
Yeah, Alexandria Drugs also has a drop box.
And so another aspect is just getting the word out that those are there and why it's important. So that's another next step.
And back to the naloxone thing, those folks that by necessity are prescribed those painkillers, some people do need them. By that, we want to be able to give that Narcan prescription nasal spray. One of the things we like to do is when you get that prescription filled, hand that out too. Just like if you've ever taken allergy shots at home, they make you have your EpiPen at home. And we want to have that home with the people too. That way, if there is a medical, because elderly folks can take a pill and accidentally take a second one forgetting they took it. And, we see those kinds of misadventures in the emergency room and in the hospital as well. So it's not just, heroin on the street that we want to help with that naloxone bill, but it's society as a whole.
I'd like to ask a question or make a statement, and Dr. Kalfas knows me, so I'm going to watch the clock. I'm not here to say to Charlotte, I don't have to do what I know, and I don't want to. And that's why what you guys are doing is awesome. I've been very blessed not to have you touched personally by the horrible drug. And one thing that you alluded to earlier, I'm a very active person, and I was having a conversation with Chief Ward a couple of months ago. He looked at me and he said, "You know what the first problem facing Campbell County is?" And I said, "No." He said, "Heroin." And I've done a lot of reading since then, and I believe it. I believe it with all my heart. And I just, I look at that picture of that very good-looking young man, and my heart aches for you. And I just thank you so much for what you're doing. God bless you. And Kristen, that goes for you too. Be strong and just keep it up, because we got to do something. And my question to Dr. Kalfas and to Kristen and to Charlotte, I'm sitting here listening to you guys, and I'm thinking, what can we do? What would help? What would be the best deterrent? It may be already being done, but I can imagine a sixth grader being here tonight and hearing what, especially Charlotte and Dr. Kalfas, Kristen, not to downplay what you guys are doing, it's great too. To hear that, I can't imagine a sixth grader ever touching this stuff. Is there a program where people are actively getting into the schools and doing this?
No, not really.
Not that I know of. I know I'm scheduled to go tomorrow to St. Henry to speak, and I have spoken around, in northern Kentucky at different schools, but not every school. But as much as I think that for some students, it will make a difference when they hear the story, I know too that for others it probably won't, because at that age, that prefrontal cortex that we've talked about has not fully developed and will not until the age of 25. And at that age, they think they're 10 foot tall and bulletproof, and it's not going to touch them. And you've got kids like Casey who are risk takers, and they're going to try things regardless of what anybody says because they think it's not going to happen to them. The second time that Casey overdosed, the girl that was with him said, "Casey, you're going to kill yourself." And he said, "I'm too tough to die." That was his response. Now, certainly I'm not saying that anything that we can do, I think, is a good thing. So I'm certainly not saying that we shouldn't go into the schools, because I do think you will reach some kids. Unfortunately, we won't reach everybody. But, as long as we can save anybody, it's a good thing. But I don't know of any concerted effort where there's a regular, unless you all have a program. Do you all have something, Linda?
No, we do have times during the school year where we'll bring guest speakers in to talk to our students, depending on what our focus is, whether it's prom week or sometimes during Red Ribbon Week. Sometimes our health classes will have but not enough.
Right.
Definitely not enough. The one thing is, sometimes it's difficult to have assemblies, either because of your facility to have a good assembly. Sometimes that's challenging, or sometimes when you have, like if we have a guest speaker coming to the gym at our into our large gym at the middle school, you're putting 1,200 students in there, and they're in a gym where the acoustics aren't very good, and it's very difficult to keep a good focus on that. Not to say that we haven't done it and we're not willing to do it, but those are some challenges that sometimes we do face. And also, lots of times they want research, evidence-based prevention. And I don't know that we have statistics.
Well, and then what I've heard
I don't want to wait on them.
is that it hasn't been very successful, is what I have heard. Now, whether that's evidence-based information that I've gotten or not. But I know that NIDA has a program out that I think might be to use in conjunction with speakers, or, you know, and I think it would fit into the curriculum of schools, and that is about the brain chemistry, the physiology of addiction. And I think that, you know, that is something that we've not tried with kids before. You know, we've tried the DARE program, and we've tried the speakers and those kinds of things. I don't think that we've really ever tried to educate the kids about the brain and what can happen. And I don't know if, you know, scientifically, if we approach it that way, if we would have more success or not. I don't know. But I do think that definitely it you know, might be a good approach to try, and certainly would fit in, having been I'm a retired teacher, so I know that they always want you to be teaching something that's, you know, they're going to test, you know, that will be on the test, you know, or we did like time on task at one point when I was teaching. So, you know, I think it would definitely fit somewhere in the curriculum, so that the time spent on it would be considered of value. And that's another thing, when you go into schools, you know, they want it to be something that's going to be their time well spent, that they can prove that, you know, they're spending time in a good way, in a valuable way, to educate the kids. And certainly, you know, look at all the young people that we're losing. Look at all the promise that we're losing. It's just, we've almost lost. Someone said to me, we've almost lost a whole generation to this. So, what could be more important than teaching kids about their brain and the effects of drugs, especially heroin?
And not just the students. My point I was making when I heard this from Chief Warren. And no idea.
Right.
I know there's a lot of people that do not know.
Oh, I'm school.
Absolutely.
Get in touch with these people.
Well, for one thing, talk about it. Like I said before, talk about it to anybody you're talking to. When Casey died, I said if somebody stood in front of me in the grocery line long enough, they were pretty captive because they had to be there, you know, to pay for their groceries. So I had a captive audience, and before they checked out, they were going to hear about Casey, the disease he had, the law. They were going to get the whole spiel, whether they wanted to hear it or not. And I take Casey wherever I go. You know, I wear a charm on my bracelet that has his picture on it. Invariably, somebody will say, "Oh, I like your bracelet." Well, that's a picture of my son, Casey. He died from the disease of addiction. I'm in the door. I'm talking. You know, that is what we have got to do. We have got to stop keeping this a secret, keeping it locked up in a closet somewhere. We've got to talk about addiction as we would talk about cancer, diabetes, hypertension, any other disease that's out there. And until we do, it's going to be hard to change anything, because you're right, awareness and education have to be at the forefront of this. You know, it's like he was saying, you know, he had no idea about it until he came.
How about making it in the workforce, having people go to different companies and things like that?
Well, and some companies do have employee assistance programs where they do help people get treatment, and I know the Alcoholism Council does have a person on their staff that goes into workplaces and helps them to set up a EAP, employee assistance program. But I don't know how widespread that is, but I think it is a good idea, because look at the employers that are losing valuable time and dollars on employees that can't come into work. because they have an addiction problem. The loss of productivity. If you figure in the loss of productivity, the amount that we're spending on health care and on criminal justice, you're talking for every dollar spent on treatment, you're up to about $11 in savings. It's worth it.
Right.
Treatment is worth it. But I think one thing that's happened is that, you know, we send somebody to treatment for 30 days. And then we expect them to go out and have a nice life. It doesn't happen. I hope you heard what Dr. Kalfas said about what it takes, the time that it takes for the brain to even begin the healing process. This didn't happen overnight, and it's not going to get better overnight. So, you know, we're not willing to give people time. I remember sending an email to Dr. Kalfas. This has been a while back. And when you were still at the treatment center, Dr. Kalfas, and I emailed you and I said, so what's it looking like for the heroin addicts? And you said we'd gotten a whole new group of heroin addicts, and what they needed was the tincture of time. We're not willing to give people time, but we're certainly willing to be judgmental when they leave after a short period of time and they don't manage to stay sober. And another thing, you know, we talk about relapse. You know, again, it's a brain thing. It's a brain thing. And the brain has something called euphoric memory. It never forgets. And that makes it really hard for people to stay sober because that brain still remembers what it felt like. And what Kristen didn't say, but what I've heard is, imagine the best orgasm that you have ever had in your life. Okay? I'm going to get graphic. And multiply that by 1,000.
I said 10. And
still you're nowhere close.
Always chasing our first time.
So, and never getting there. Never getting back to that place again. So when you say that you fall in love with it, there you go. Yeah. Right there.
The comment about the workplace, you know, for especially with pill users who haven't quite graduated to heroin yet, that's one of the biggest problems. I see people 20 to 40 in my office, and one of the barriers to their recovery is the fact that everybody at work's doing it. Their dealer's one of the guys they work with. You know, one guy I just talked to recently, who's a friend of mine actually that I'm treating for his addiction. He was addicted to painkillers, and he brought in one of his coworkers who's addicted to painkillers. One of the guys in their shop is getting prescribed 150 Percocets a month. And he takes 30 of them and sells the other 120 to the guys he works with. So the whole shop's addicted. So the workplace issue is definitely valid. I like where Charlotte went a second ago, and I'm just going to be quick with this, I promise. But, you know, I hope by now everybody buys into the idea that this is a disease. Every disease since the beginning of the 20th century that we've beaten, or that we've at least curtailed. How have we curtailed it? You know, stage 4 cancer is still stage 4 cancer in most cases. We don't win jumping in late. We win through early diagnosis, detection, and prevention. And if this disease is going to be like any other, that's how we're going to beat it too. And that means, and you know, and this opens a little bit of a can of worms. You know, for some of these kids, it starts with smoking pot. You know, when I was in medical school, you know, I wasn't sure I bought into the gateway theory of marijuana leading to drug abuse. Boy, it does. And like Charlotte was saying, that prefrontal cortex not being developed, when you have young kids smoking weed, that's priming their brain for that addiction later. They're more likely to get addicted when they try other things. And if you want to debate, I mean, I'm not going to present all the data on that. There's a lot of scientific data to support that. So it's not just, you know, well, let's go out and just talk them out of doing heroin. No, don't take the Xanax out of mom and dad's cabinet. Don't be smoking pot. Don't be drinking. You know, that's not where they start. Whereas a large percentage of middle schoolers have tried heroin, a scary percentage, a lot of them didn't start with heroin. That wasn't the first thing they did. I mean, even in Kristen's case, you know, it was started with a prescription. And Roddy, to answer your question of what do you want us to do, that kind of gets back to Kristen's case. You know, I just want y'all to care. You know, when you see somebody like Kristen struggling, you know, she's just gotten clean. You know, check on her periodically. Ask her how she's doing. It might be a matter, she might need a ride somewhere. She might need, you know, the same you would do for anybody with a disease, you know. Like Charlotte said, you know, if I said my son had cancer, I'd have a table full of casseroles. You know, help, care. When people want to do something about it, get on the bandwagon. Don't fight it. Don't pick at the methadone clinic that's trying to help people. Just care. That's the first thing. And God's going to use your talents once you give them. You just got to let that happen.
No, I struggle with it every day, you know, and through rehab, I did learn what I needed to do when I went to that dark place. I knew to call someone, and I know what my triggers are, but I'm gonna fight this disease my whole life. You know, once I turn my back on it, and turn my back on God, that's when it's gonna come back and get me. So I can never forget that I have a disease.
If I can say a piece about prevention. I know you've heard the panel mention a couple of times the Northern Kentucky Heroin Impact and Response Group. There's a couple different pieces to the group. It's kind of made up into 4 different subcommittees, if you will. And there is a prevention piece. There's several of us who are here tonight, and that's basically our entire focus. We know that more awareness needs to be brought to the community. That's one of the things that we're doing, you know, with our coalitions. There's 8 coalitions in Northern Kentucky. So, you know, Northern Kentucky reaches down into the rural counties as well. So there's 9 coalitions. And everyone's kind of taking a focus. But there is a committee. We're working very hard. You know, with prevention, unfortunately, it's like taking little baby steps. You're not going to see these fast results. We want fast results. It's just going to take a lot of work to get there. But we have a lot of people who are very committed to trying to figure out what do we need to do. And this truly is, we just met 2 weeks ago, and this was one of the things. It was, let's bring awareness. Let's let the community know that this is a problem. And hopefully, too, by saying that this is a problem, we can help say, and this is where you can go for answers. This is how you can help. So I just want to say, you know, there is a prevention piece. We know we're not moving quick enough. We hope to move a little faster, but
Join the Campbell County Drug-Free Alliance. We're always looking for more members. This is, you know, one of our projects we talked about was to create this town hall meeting. We're doing that in several locations in Campbell County, but we meet the first Wednesday of every month at 8:30 downstairs. And we would love to have any participation and support and help.
Tyler will let us go early for practice if we need to do that.
One other statement that I want to throw out is, from what I've read, everyone knows no socioeconomic classes, race, anything. And have you done any work with any of the local churches? Because those are people, not that everybody's not caring, but churches have people that are.
We do have 2 churches, local churches represented on our coalition, and we're always open we're always open for that, yeah.
And don't forget the PAR meeting next week, too. The PAR meeting, People Advocating Recovery, next Wednesday, 6:30, Grateful Life Center. So, and then the Heroin Impact Committee, too. I mean, you know, you can see Sarah get signed up and get on the list for that. So there are lots of opportunities. We've got more opportunities now than we have ever had before for people to be involved, more than we've ever had before. So.
We have talked to Michelle Snodgrass, who is the assistant attorney, and she is actually thinking and working towards having some of the inmates who are convicted sentences of heroin to come to the schools as part of their sentence in community service. So that's something we're looking at as well. also, Kristen, myself, and my sister, we have a heroin awareness committee. We do hold rallies, we hold meetings. We just had one at Susan's Salon on the 19th of March, which we had about 70 people show up. It was wonderful. I think a lot of people left there very well educated about things. So we do have that. Usually comes in like the Campbell County Recorder. It's usually advertised in
There's
there.
a Facebook page for it too. It's called the Heroin Awareness Committee of Northern Kentucky, which Kristen actually started that. And we're going full force with it, so.
Okay, great, thank you.
If we can do anything.
Okay. And if you would be interested in being a part of the Campbell County Coalition or sit on the impact, you know.
We are in the impact.
Okay.
We are in the
Terrific, great, thank you.
I have a suggestion. Kids, you can talk to your blue in the face. Some of them might hear what you're saying. But when I was a high schooler, I remember the fire department, I grew up in Claremont County, put on a spectacular, dramatic, gory show before prom. And boy, they didn't forget that. So here's my suggestion. Maybe we can put on a drama. What does it look like when somebody runs in the front door of the ER and says, "There's something wrong with my friend in the car," and the nurse goes out, the kid's blue and not breathing. And then you find out after much trying that, oh, it was heroin, and you've already given them the Narcan, they're awake. And, you know, and maybe show them one where they don't make it. You know, that might drive it home. They might remember it a little more than just talking to them, but they still need to be talked to, and they still need to know this. But I know I do have a 6th grader in Campbell County, and next year I'll have a 6th and a 7th grader. And I also work in the ED at Fort Thomas, and I've seen it from every community. And it is scary. And it is hard. It's really hard to see it every day and try to be hopeful and try to be supportive and try not to condemn these people. We do try. We really, really do. But we wish there was a way to stop them. But let's get our kids so they don't do it.
We probably need
Could I just say something about, when we talk about these people, you know, they're our children. They're our children, they're our moms, they're our dads, they're our sisters and brothers. You know, I can remember when we were trying to get property for the Grateful Life Center. And whenever we would go out to these town hall, to meetings, like a meeting tonight, and they were, people who have this disease were referred to as those people, and not in a very good way. It just broke my heart every time I would leave the meeting, because, you know, I think sometimes we have a tendency to refer to people who have the disease of addiction as if they came from some other planet somewhere, but they came from homes like mine. They came, you know, as you were saying, this is a disease that does not discriminate. It's an equal opportunity disease. It doesn't care who you are, where you live, your economic status. It matters not at all. So.
One question I have is about being an addict is, you know, they need rehab and not jail. You know, that's why we're doing is talking to Dr. Kalfas and St. Bees, and, you know, we try to, it's a balance. You know, when's a point where they got to keep going to jail, and then we get help for them so they want to quit. You know, but we can't let them be a scourge on society if they keep stealing or robbing and killing. I mean, so that's where the balance is, trying to get them help. You know, some people don't want help, unfortunately, and that's what we're trying to reach out and we're trying to do. That's what we're trying to do. And the other is about calling the police. Keep calling the police. We have a drug unit. We pass our information on because we want to have the sources and the resources to be able to do all the investigations we get. You know, sometimes it goes across state lines, across county lines. So if I get some information, we pass it on to the proper authorities. So keep calling and keep helping, and so we can try to get.
I had a question. First question is, do the increased beds, the 58 beds, will that include treatment for minors? There's nothing in the license that says we can't, and so that's certainly something we're considering. That's probably not the population we'll start with. but there's nothing to say that some of those 58 beds can't be allotted for kids. And then the other question I have is, where do you find mental health counseling while you're in recovery? And so that's certainly what we intend to offer through our intensive outpatient program. In addition to our intensive outpatient program, we also offer aftercare programs, and those are led by qualified mental health professionals. So there's another avenue to receive support.
I had the last question I had was, how do you treat a person who's addicted to Suboxone? It's a good question because there's a lot of both misuse and misconception. What Suboxone is? Suboxone is taking an old drug called buprenorphine. Buprenorphine's been around 30 or 40 years. In pharmacology, it's what we call an agonist-antagonist drug. In other words, if you think back to what I said a moment ago about the lock and key analogy, if the lock is the receptor and a key is the drug, well, the opiate drug that the person's addicted to is like a key that goes in the lock and turns and the door opens and something happens. What Suboxone is what's called a partial agonist. It may go into the lock, turn a quarter turn, and break off. Yeah, as a key. It's like a key that does that. If you can imagine a key going into a lock, turning a little bit and breaking off. So now the lock is full, it's not empty, and you're not craving, but it's not stimulating. Now, obviously, every opiate drug is going to react somewhat differently in some people's bodies. For the most part, a person who is opiate addicted and opiate sensitive is not going to have a buzz or euphoric feeling from Suboxone. I'm not going to say that there isn't the occasional person that can, but that by far the norm is to not get any benefit as far as being high or getting a buzz or anything off of Suboxone. Is Suboxone misused? Yes. The primary way that I see it misused is, let's say I'm an addicted person and I'm trying to function. If I've got a job, I work 3 days a week. Well, I want to be able to function and not being withdrawn, go to work 3 days, but the other 4 I want to use. I'll go see a doctor, get my Suboxone. I'll take it my 3 days. I'll sell the rest to buy dope, and then I'll get high the other 4 days. So that's how I see Suboxone being misused the most part. So I really don't see people a lot. I'm just going to say a lot. I'm not going to say it doesn't happen. But I don't see a lot of people getting addicted to Suboxone. What does happen is you become physically dependent on it. The same withdrawals that you have when you come off of heroin or another opiate are going to be there. If you're taking Suboxone regularly and you stop taking it abruptly, you're going to get the same withdrawal. And it actually catches people by surprise because they think, wow, I feel so normal, I don't feel high. Why, when I stop taking Suboxone, did I go into withdrawal? And that catches them by surprise a little bit. But you do get pretty significant withdrawal when you stop taking it abruptly. The answer to the question is you wean them very slowly. If someone's on 10 milligrams, I'll get them down to 9 milligrams for a couple weeks, then 8.5, and then 8, and you have to consistently wean them. The very first patient that I put on Suboxone 10 years ago is still on it. However, he's not had a dirty drug screen in 7 years. He's a good father. He works every day. He's got 2 beautiful kids. Judge of success. The answer is different for everybody. What Suboxone is, what Vivitrol is, what methadone is, what counseling is, they're all tools that we use to help people. Tools are being developed, and it's up to the people treating. We've got to figure out how to use them. I'm not sure that what I do with these things is different than I did with them 10 years ago. I'm always learning too. I learn from my patients. They've taught me some things. Sometimes the best thing I can do for a patient is to shut up and listen to them. But most of the insight I've gotten from drug is from my addicted patients. So Suboxone is not the end all. It helps a lot of people. There are some people that functionally learn how to abuse the drug. And sometimes I've had to send those people. The last guy I had doing that, I sent him to detox. He went to an inpatient detox unit. Detox went through withdrawal for 7 days, got a Vivitrol shot, and he's been clean 4 months, and he's on the Vivitrol shots now. Again, using the different tools for the different people as they're available.
I was just going to say, Dr. Kalfas told me, after Casey had passed away, he said, if he had had Suboxone then, and that was 10 years ago that Casey passed away, that it might have saved Casey.
I was just getting it.
It might have been beneficial for Casey. You know, the one good thing that Dr. Kalfas hasn't mentioned, and I'm 99.9% sure that this is correct, Dr. Kalfas, is that you don't overdose on Suboxone.
Right, right.
So, you know,
Unless you're taking it with something like Xanax or Valium in a high dose.
Right.
But the only overdose, because Suboxone's a partial blocker, the more of it you take, it actually starts to become, it goes the other direction. It becomes unpleasant and starts to be more of a blocker if you take more than you're supposed to.
Because there's a ceiling
So it's
effect.
almost impossible to overdose on Suboxone like you would methadone. So that's another benefit.
It is. It is. I had a question. Do we have time for it or not? Okay. Okay.
Are we on a time? We need to go?
I'll stay here till everybody's in.
Okay.
We're all right.
You
Yeah,
call,
if you need to leave, leave.
yeah. You call heroin addiction a disease. If heroin addicts shared this definition, would this get them to pursue treatment? In other words, how can we get addicts to pursue treatment before they OD? I think one thing is that if we have more treatment facilities, so that when someone goes into detox and they're ready to go into treatment, they can go immediately. That's going to be a big plus in getting somebody into treatment and keeping them there, because you know, you've got a very small window of time. And if you don't have a place for them to go, they're going to go out and use again, and may be the last time they use. You know, we've got 11 detox beds at Transitions, 11. 3 for men, 8 for women. My son, as other people are being told still to this day, was told, you know, call back in the morning. Well, that would be like telling a person that's having a heart attack, you know, take 2 aspirin, call me in the morning, if you're still with us. So that's one thing. We desperately, desperately need more treatment. You know, we've got the Recovery Center for Men, the Grateful Life Center. We started with 100 beds. We've upped it. I think we have like 112 beds now. We could fill that up probably 10 times over. So that's key. Casey's Law is another way that we can get people before they OD. It is an intervention, and intervention is so important in getting somebody the help they need, because we've already established that with this disease, the person is not capable of making a good decision for themselves. No more than anyone who has a mental illness is able to make that call and say, you know, I have, you know, I'm a schizophrenic and I'm not, you know, I need medicines and please help me. Usually there's a mental health inquest where someone steps in and says, this person needs some help for their mental illness. Well, we've got an individual whose brain is not working, so we need someone or something to intervene, whether it be the police officer that takes them to jail that may save their life, or if it's someone that goes to court and petitions under Casey's Law to get that person the help that they need when they need it, because tomorrow may be too late. It's just like Casey was arrested one time in Indiana, and we went with 2 of our 12-step friends, and I had a legal sheet of Casey's drug history as we knew it, his overdoses and everything that we could present to the judge. And I had it, I wanted to present it to the judge that day. The bailiff told me that they weren't there to deal with that he was going to be released on his own recognizance, which he was. After Casey died, and I had sense enough to use the telephone, I called and I said, I'm calling about Casey Wethington. I would like to know the name of the judge, because I wanted to send him a letter. I wanted to send him a picture of Casey and say, the next time you have the opportunity to intervene on someone, please do so. And what the woman who answered the phone said, well, we have a warrant out for his arrest. And I said, well, good luck, he's in Spring Grove Cemetery. I said, he was released that day with the warning that he could receive a summons within 90 days to appear in court. And I said, an addict may not have 90 minutes, much less 90 days. And I said, and she said that I didn't understand how the system worked. And I told her, if that's how the system worked, there was something wrong with the system. And that's where we stand right now today, folks. There's been something wrong with the system for far, far too long. And until, like somebody said, we take the bull by the horns and say enough is enough, we're not standing for it anymore, things will continue to go status quo. As Dr. Engel will say, we will go to the default. Well, default isn't a good answer. Default has gotten us to where we are today. You know, I tried 10 years ago to tell people what was going on with heroin, and here we are. Yeah. Here we are.
And answer that question about going into treatment, just to add to that, you have to realize this is the crux of the problem. I'm going to lay it out right here. And I'm sure Kristen will back me up on this. What's an addicted person most afraid of? When you were using, Kristen, what was your greatest fear? What was the thing you feared above anything else? Withdrawal, right? Being without it, detox, being locked in a room that you couldn't leave from, and being sick. So when you go to somebody and you tell them, gee, you need help, I'm going to take you to detox. They want to run like, you know what? We've got to have the appropriate facilities for them to go to. And they've got to not be afraid to go to it.
And that's what Casey's Law does. It holds on to people long enough for them, like Richard said, to want to. Because initially, there's the fear there, and also they're not capable of wanting to at that point, possibly. So you've got to hold on to them long enough for the mind to begin to clear a little bit and for the brain to begin to try to function, quote, normally again. So if you can hold on to people long enough, it can happen.
John's had his hand up like for 20 minutes, man. What are you going to?
I had just 2 questions about, I was a little confused about the drug that you were talking about, that doesn't let the key go into the brain, make the connection. I don't understand it too well.
Okay.
You said some people are on it for 6 months, some people are on 2.5.
No, he was actually talking about the Vivitrol, the shot, right? The shot one?
Yeah, the one, the message put in to bring people back.
Well,
It also,
right.
People. What I don't understand is, if this is truly an addiction, and addiction is a mental issue also, why don't they prescribe that drug constantly, make that person come in on a monthly basis to take that shot until their body no longer accepts that shot anymore, or they become used to it?
Well, there's no objective way to know when the person's done. I mean, when a patient starts on that drug with me, I usually tell them, I really want to get you on it for 6 months. I'd love a year. And at a year, you know, I look at how that patient's doing in recovery. You know, are they going to meetings? Are they sober? How are they feeling? I'm like, are we ready to try not doing it this month? And, you know, a lot of times they'll say no, and we always get that one extra shot or two because but in general, it's going to be dependent on the patient. I mean, you're treating a person. I can't just say, well, I'm going to make you fit into this cookie cutter mold. I mean, I'm working with you through it. But the point of it is to both help stabilize your brain chemistry and prevent the craving, as well as give you some insurance against a relapse while your brain chemistry is renormalizing itself, while it's reestablishing normal. While those chemical imbalances brought about by the addiction and adding all these chemicals into your brain. I mean, it's the same thing with alcohol. When you're drinking on a regular basis, you're changing the chemical structure of your brain on a chemical level at least, and your brain does other things to balance that. And when you stop drinking, if you look at an alcoholic who hasn't drank for a month, man, they're struggling. You know, they can't focus. They're irritable. I mean, there's a lot of overlap in these problems here. And what you're waiting for is the brain to readjust and put itself back to normal. Sleep is a mess. They can't sleep. So the idea of using a medication-assisted therapy, let's give that brain time to recover so the person is thinking rationally, they are able to help themselves. And at the same time, you know, medication alone isn't going to do this. They need to be going to meetings. They need to be seeing a counselor. Like I said earlier, these are folks that, you know, if you're 25 years old and you're addicted and you've been using drugs since you were 16, guess what? You respond to problems like a 16-year-old because you're used to getting high and not dealing with it. And you have to learn coping skills. And the first thing that makes you want to go out and use something is when a stressor hits your life that exceeds your coping skill. The next thing you know, something bad happens in your life, and boom, your first response is, I don't want to deal with this. I want to go get high. Because at least then I'm not thinking about it. And you have to learn those skills, and it takes time. That's what treatment is.
One fallout is like the computer popping back on. So you're saying after your treatment, you can just have one bad day and take a shot and you're right back to square one.
Yeah. And and it gets harder and harder to boot that screen up as time goes on, but it's still there. And
And a lot of times they do as much as they thought they could have, and that's their best time.
Right. Well, that's where a lot of overdoses occur. Is someone who's been clean for a while. They're saying, I used to be able to shoot a quarter gram or half gram.
We see a lot
They just got out of jail.
As soon as they get out of jail, they go back
They
to
go
what
out-
they did before.
And now they don't have the tolerance for that, and it's an overdose.
So addiction of many different things. Is there a chemical imbalance just for addiction itself that we can isolate?
Actually, there is, and I'll try to say this briefly, but basically, that's what I was talking about, the limbic system in your brain. That's where addictions and instincts and things like that lie. We know that if you're anybody that is interested in anatomy, it's the ventral tegmental area, which is the anterior part of your brain. It's below the cortex level, and there's a whole string of dopaminergic neurons in that area that are responsible for what we call reward circuitry, and they overlap one drug to another. Actually, other drugs can input in the systems of other drugs. It gets really complicated, but the bottom line is there's this complex system of interactions, and believe it or not, even something like gambling can trigger some of the same dopamine surge responses that a drug addiction can do. So there's a lot there. I mean, that's a whole day of classes at the ASAM review board. But
Thank you.
I think if anyone has any last remarks, I think we need to kind of wrap things up. Does anybody from the panel have anything you want to add?
I think I yacked enough.
Yeah.
I'd like to make one comment. I'm Bill Rath. I'm the mayor of Alexandria. And I would like to thank you folks for coming here. And I'm going to tell you that we are pleased, and I'd like to acknowledge our couple of city council folks, Joe Anderson and Andy Schauble, who were instrumental in passing the ordinance that allowed the city to create an office space here. So once this grant goes through, you all have an office here. So as soon as you get your phone put in, make sure you get your phone number out. People will be able to come talk to them, so you'll have a place that you can use. Personally, I lost a sister and a nephew to drug usage, so I can relate to this problem, and it's not going to be smaller. So thank you all for what you do.
Thank you.